Well, thanks everyone for coming back. I know it's been a long day, and I know that people have really been wrapped with attention. I know I have. I've been tweeting all day from up there. If you want to follow me, it's at Corinne Carey. My name is Corinne Carey. I'm the Assistant Legislative Director for the New York Civil Liberties Union, which is the New York affiliate of the ACLU. And I just have to thank Deb and thank the organizers for inviting me here. For the past few years, I've been sort of slogging away in the darkness of our policies and procedures committee in New York, setting up our own health exchange. And it's lonely and it's complicated work. And it really feels like I'm coming out into the daylight being here with you all. So thank you for inviting me to moderate this panel. I'm really excited to have the folks that we have with us today to talk about health data exchange. What is it? What to do, whether to opt in or opt out. We've got some really exciting panelists. Helen Oshalowski, and I think I didn't say it. I said it right
Better
before.
than I can pronounce it.
Anyway, is a corporate and regulatory attorney in private practice, advising healthcare clients. She used to be, or I think currently still is, involved with the New Jersey Health Information Technology Commission and blogs about issues of patient consent. Mike Davis is a security architect. He's on the screen up there with the Department of Veterans Affairs. He helps develop technological architecture to operationalize patient privacy principles and preferences, and he helps bring security tools to aid privacy protection aims. And finally, Randy Farmer, who's currently the Chief Operating Officer of the Delaware Health Information Network and comes to this work from the private sector and financial services. So it's an exciting panel. You can read more about each one of them in the program for a more detailed bio. But I just want to start out with a few remarks. When I agreed to moderate this panel, I agreed, and then probably a month later looked at the title, and I thought, this feels like a misnomer. What does it mean to have the option to opt in or opt out? Because in New York, we have a very strange system where all of the information is uploaded into a system that is capable of sharing. And the theory is that you have to get consent from patients prior to accessing the data. But as you can imagine, the exceptions are beginning to outnumber the rule as the days go on, which is part of why I've been slogging away at that policy work. But I'm happy to hear when I convened a call with the panel that New York, while not alone in that, there are some good examples elsewhere, so that there are places in the country and around the states where there is truly, or at least as close to true as possible, where there is a choice between opt-in and opt-out. And I have to always remind myself that New York is not the center of the universe and that there are some cool things going on elsewhere around this question. I want to reiterate a point that Catherine Sirks made earlier today. She talked about audit protection, breach response, and getting the HIPAA stamp of approval, which is what everyone is always looking for in New York. Is it HIPAA compliant? If it is, it's okay. She's talking about that being, those three things being relatively meaningless, and that what's really important is a patient's need to know. And unfortunately, I think at our state level at least, that's become the least important priority for our Department of Health as they operationalize our health information exchange, is doing a public education campaign to let people know what's happening with their health information. But then, right after I was excited by Catherine mentioning that this morning and thinking about how we protect privacy outside of the HIPAA realm. Someone in the audience stood up and totally killed my buzz around this and said that as patients, we have no standing, that we're not the customer, we're the products. So that was sobering. But I do think that later on we heard a reiteration of what I've always said, that patients won't communicate with their doctors unless they trust the system. And so the doctors, in some ways, being part of the consumer or the customer base have some interest in protecting patient privacy. So with that, I'm going to turn it over to our panelists, and we'll ask for questions after the three of them give a brief presentation, and I've got some questions of my own. So I'm going to turn it over to Helen first.
Okay. Thank you, Corinne. Thank you again to Dr. Peel for inviting me and letting me be a part of this. I've learned so much from everybody, and thanks everybody for joining us during this session. My name is Helen. A little bit about me real quickly. I was at a national law firm for about 10 years, and about 4 years ago I broke off and now own my own boutique. And in that capacity, have had the privilege the privilege of working with dozens and dozens of health information exchanges and healthcare systems in the tri-state area, both in Pennsylvania, New Jersey, and in New York. As Corinne mentioned, a couple years ago, I was appointed to a technology commission by former Governor Corzine, and then subsequently reappointed by Christie. And in that role, had tried to develop, from my experience and practical experience as well, some guidelines as to how New Jersey would move forward with network health information exchange. So to the title of our panel, what is data health exchange? Should you opt in or should you get the hell out, if you will? And I want to start by kind of giving my opinion on that. It really depends on who is trying to access your information. In my opinion, who's trying to access your information and for what purpose. And the answers to those questions vary. And the dedication of the particular organization that's trying to set up an infrastructure, both technologically and from a legal framework and from a governance framework, will do the success at which they are able to control the answers to those questions will range, okay? So I think many patients would feel a comfort level of their doctors, their treating of record treating physicians, being able to gain access to critical information about them in order to make a full decision about them that can affect their health and in fact, do something detrimental if they didn't know it. On the other hand, would they feel equally comfortable if they knew that their health plans had carte blanche access to data fields for not only in connection with treatment, but also with making some certain kind of coverage decisions or insurance decisions. And so, it's critical to understand. And I'm going to give you example today of one particular health information exchange that I was involved in and started to get involved in and continue to involvement to this day for 4 years. That I think tackled these issues in a most thoughtful way from beginning to finish and continue to do so, and would be an organization where I would feel comfortable with my health information going and being able to be data exchanged. So Virtual Health System is a multiple healthcare system in central Jersey. It's comprised with a number of acute care facilities, ambulatory facilities, long-term care, health care, and everything in between, as well as medical physicians that are captured PCs of the healthcare system. When they started to first contemplate networked health information exchange, probably more than 4 years ago, I got called in 4 years ago when they started to think about how are we going to do this legally. And the fact they even answered that question or asked that question to start shows their commitment to doing it the right way. But when they first started this up, they called in. They started to assemble teams. It took almost 2 years of planning before they even deployed anything, before they even went to testing phase. That kind of commitment to the process and thoughtful planning, I think it really demonstrates the kind of organization that's really committed to doing it the right way. They first established a number of committees within the organization. They established something called an HIE council that was made up of the general counsel as well as a number of other executives that would have the final policies. Anything that happens on a big decision level would have to get vetted through the HIE council, changes to agreements, everything would finally have to go through approval. Sort of like a board. This is not a non-for-profit. I know that there's a range of kinds of structures for these things. In many instances, you may hear of separate 501c3s being formed for stakeholder collaboration. That certainly is a great way of providing a neutral kind of body and stakeholder input from a number of kinds of organizations. In this particular instance, they were focused on a community and system, and it is a hospital-based private sector, but yet since they couldn't have a board, so to speak, or they already had a board, they established a committee through resolution that was charged with the specific task of reviewing everything and approving things at the highest level. They also involved established a physician usage committee, so they got the clinicians involved. You know, it's no good in putting out policies and telling people to do if the doctors aren't going to do it and if it doesn't work for them. So they got the VPs, they got the VPMA involved, they got the clinicians, the people who are in the trenches who are actually going to have to do the data sharing, and got their input. Is this consent? Are you going to be able to ask the patient consent when you're in an interaction with them? Okay, you can do it this way, you can't do it. What's going to work for your workflow? So understanding, we heard earlier today, you know, these processes are only as good as the effectiveness of how you can implement that, and you can't figure out how effective it's going to be until you actually get, you know, the workers to tell you, the clinicians to tell you whether it's feasible and vets with workflow. So we got a physician usage committee that all these things went through them and ran through them, and we got their input on. And finally, the committee that I was involved with is the Privacy and Security Committee. It was comprised of we heard earlier the security director for the health system, the IT people. There was a project manager, the CIO, the health information management director, who used to work with paper and now is ripping her hair out that things are moving in faster than, you know, she knew what to do with. It disrupted a lot of things, and not disrupted, but it changed. The world is changing, and it changed things for their departments as well. But it was important to get their input. It involved the privacy officer, who doubled as a patient advocate, because she said, I swear to you on day one, I'm opting out of this thing immediately, and then we'll figure out if I want to get back in. So we had a great collaboration, and again, a testament to the commitment, and everybody brought a viewpoint. Everybody, you know, brought a point to the process as we were developing policies, as we were developing contracts, as we were developing consent frameworks. The IT director will say, we can't do that. Or the HIM director says, well, on paper, we get a consent every single time, so now you're telling me we don't need consent. So this input and process went on for a year. And what came out at the end, hopefully, was not like a sausage, but it was something really like a filet mignon. It was, I feel, something that was really effective and was really thoughtfully put together. So in addition to the committees, the other thing that I think that is a critical piece to this is carefully selecting your technology. So many times, I shouldn't say so many times, at times I have gotten involved with a number of HIE initiatives where they quickly just grab the cheapest product out there, or somebody who was able to sell them the bridge. And they went with it, and then a year and a half down the line, they realized this stuff cannot do what I need it to do. And then they got stuck. And some of them got stuck, and they had to flip, and they had to change technologies or whatnot. One of the things that Virtua did that was really, you know, to their testament, is they very carefully vetted technologies. Did they go with the best one? Did they go with the worst one? I guess that's a matter of opinion, but they went with one that really works. And one of the things that made it work, they went with Alere, if anybody, it used to be called Wellogic. But one of the things that made it effective is that this particular company was willing to work with the system. They were willing to program. They were willing to customize certain kinds of solutions when we hit problems from a policy and process perspective. And that was key and critical. So many times you run into technology vendors who are like, this is the way it is, take it or leave it, we can't do that, and there's no workaround, and then you get stuck. The other thing that was really interesting is they went ahead, and technology, as you well know, it always comes down to investment and money, but in this particular instance, the system was able to and had the resources. They invested in a groundbreaking, in my opinion, application 4 years ago called Enable Care. And that was an app that integrated and sat with the major HIE technology, and it scrubbed the data, it read it, looked for keywords that we developed from a legal standpoint, tagged it, and then sequestered it. So maybe I can see the fact that you have allergies, but I'm not going to see that you got tested for an STD. That's behind a break glass, and it's completely invisible. So it allows the clinician who's treating the patient access to general medical information that's important, but will require the clinician to ask for episodic consent at that point in time to break the glass to get anything that's sensitive. So it was their approach to that issue. So, yeah, so we carefully then went to vet the consent issue, and we considered all the possible the other possible models with consent. About the same time when we were vetting this, about 2010, GWU issued a white paper that put out the various models of consents that they were able to assess that were out in the field in the 50 states right now. They recognized that there was no consent. You're in, and basically we do what was out there. And Virtual looked at it and says, we can't do that. You know, right now we require consent, and patients would have no trust in the system. We can't go with that model. They said, okay, maybe we'll do an opt-in. We looked at opt-in, we vetted that. One consent covers everything. And the committee said, you know what? You know, I know that a lot of places are using that. You know, they get this blanket consent, and then they basically do what they want, or at least there becomes a tendency to think that you can do because we have the consent. And so they felt that this was not protective enough. They felt like getting a blanket episodic consent did not offer enough protections because they felt like it would lend itself to a sign here approach and a misunderstanding that you can now do anything you want with it. So they moved to granularity of choice. And it was an option, but unfortunately, right at that time, from a cost perspective and a limitation in technology, we didn't have, you know, patient portals that were robust enough to do what we wanted to do with it. So we could not implement something that allowed a granularity of choice by the patient in management of their health information. So they went with an opt-out of information. So all your data goes in, okay? We put the application of Enable Care on. We block out the sensitive information, require episodic consent, and we allow the patients to opt out of the whole damn thing if you want to anyway, which our privacy officer did in the beginning, and now she's back in. So that was what they went with. They, you know, looked at the data segmentation white paper. NIST was giving recommendations. It's, you know, the concept of data segmentation goes way back, way before even PCAST brought it up. It seems to think that's something that's getting a little bit more traction now. But, you know, it's something that in 2008, in February, NCVSD, the National Committee on Vital and Health Statistics, they've been recommending sequestration for years now. It's just that nobody seems to be paying attention, or at least have not been doing anything on it. The HITECH Act in 2009 mandated and directed the HIT Policy Committee to make recommendations for technologies that protect the privacy of health information, including segmentation. Also, in that same act, the same legislation, in another section, it required the national coordinator to ensure that the relevant and available recommendations of the NCVS-HS with regard to sensitive information were considered in development and policies. And then in 2010, HCVS-HS provided defined categories of sensitive information, things like, you know, what we heard earlier, genetic information, mental health information, Part 2 information, all this sort of thing that we need to take into consideration that maybe it's not the same as all other information, and it's not adequately protected. And of course, we had the PCAST report. So the next step is, you know, real quickly, I have a minute left. You know, we went, essentially our next step was to develop, you know, processes around these. We clearly defined what were permitted uses, and we basically started with treatment, and that's it. We said, okay, for treatment, we clearly define who are authorized users. They're not health plans, and if, you know, they're not going to have, we're talking about who has access to the entire data bank of clinical information, which in and of itself was still initially limited. We developed an HIE brochure that informed patients. We developed web pages that listed all the providers who have access to information, organizations that were involved. It allowed the consumer numerous ways to opt out, including on paper, phone, and electronically. And of course, we did get consent forms and your NPPs. So we implemented the baseline, we created sensitivity to sensitive information, and we got episodic consent for sensitive categories of information. You know, and is this the right way, the wrong way, something in between? You know, it is in the end, something that, again, I think was thoughtfully put together. If we're going to have networked health information exchange, we have to put in place structures that are thoughtful and instill in consumers, you know, trust. And this is, you know, one example, and there are many others that are starting to circle back and, you know, come to me, come to others. I think that this is an opportunity. So an opportunity to really put in place to allow clinicians to share information, to do wonderful things with data, but definitely we can't, you know, go forward unless we put in place the foundation, carefully thought through foundation to make sure that patient information is kept secure and private. Thanks.
So we're going to go to Mike up on the big screen. Is there any way to get rid of this little box, or do we just deal with it? The orange arrow. Great. Welcome, Mike. take it away.
Okay, thank you very much. Thanks. Very interesting comments. I'm with the Veterans Health Administration, which is portion of the Department of Veterans Affairs. I'm the security architect there. And I say that because I work closely with the privacy officer. I am not the security guy that takes your thumb drive away from you. I'm with the business side of the Veterans Administration, and I principally represent clinicians in dealing with security issues. So this particular issue of opt-in and opt-out, whether you choose one or the other, I'm going to try to give you a little experience from benefit of our experience and some thoughts that you may find hopefully useful in going forward. So currently VA is 100% opt-in. The patients must sign an authorization for sharing of information. This is all patients, all veterans must sign this. This policy was put in place originally to protect what we call restricted health information, and that includes HIPAA-covered health information that may be additionally protected by more stringent organizational or jurisdictional policies. So this could be state policies. It could be things like 42 CFR Part 2. The VA is specifically under a law called 38 U.S.C. 7332, which requires protection for drug and alcohol abuse, HIV, and sickle cell anemia. Things like HIPAA self-pay provisions that Helen mentioned may certainly apply, and you may have things like patients self-requested that they not participate, they wish to opt out, or you may have VIPs, you may have employees. So you already probably have categories of individuals in your organization that probably require an authorization anyway to participate. So it's unlikely that anybody's going to be all one or the other. Anyway, the VA enforces this policy by an enterprise access control system, which ensures that a valid patient authorization actually exists prior to sharing of any PHI. This is an automated system, operates at the network level. The pros of the opt-in approach for us is that it guarantees patients have a choice for the sharing of their information. If they don't sign an authorization, we don't share it. It also guarantees that the VA cannot mistakenly share PHI that might require an authorization that we somehow miss. All veterans are covered by default. In several years of operating of this system, however, we found there are some cons. First of all, it's burdensome to veterans, and we're dealing with a huge population. So whatever I say is in the context of millions and millions of patients. So if we just had a few hundred, a few thousand, maybe a few tens of thousands, we might have a different view of this. But we have to get authorizations on millions of patients, including millions of patients that are not otherwise required to have an authorization under HIPAA, but are required under Title 38. So the enormity of the problem is that it presents to us a significant administrative overhead, and particularly whenever manual processes are involved. To simplify our opt-in effort, we did implement electronic mechanisms to simplify the process. There are multiple ways that the veterans can reach the VA. There's patient portals, etc. To simplify the opt-in process, we implemented these mechanisms where veterans can view and electronically sign an authorization. So this is very significant that we have an electronic process with an electronic signature, not a manual signature. We simply cannot deal with millions of paper-signed records. They have to be electronic, and to get these into the system currently, once the patient electronically signs the authorization, it goes directly to the access control system, do not pass go, and can be enforced in a matter of seconds, milliseconds. So we also have pre-approved restriction requests to complement opt-in to allow certain restrictions on the exchange, most notably by organization. The bad to this approach, it sounds really great, is that these individuals have to be identity proofed, and we have to give them logon credentials. That means they all have to come into the VA. They all have to go through some in-person process currently. It's not suitable for all veterans. All veterans, we have an older population in many cases. They are not computer literate, so paper processes must still coexist in this environment. Not everybody wants to be a computer guru. So that's our situation right now. That's what we are trying to deal with. The results have been, over the past few years, that we've been able to get authorizations for some tens of thousands of patients, but not hundreds of thousands and not millions of patients. So this is, in a way, a disservice because the process has turned out to be very difficult. So I'll talk a little bit now in an architectural sense, hypothetical sense, about what could be done to improve the situation. So if you think about most of the population under HIPAA, they would be normal records, what we would say normal. Their records can be shared without an authorization. That's what HIPAA allows. So in the case that you have restricted populations that do require an authorization, you could do that if you had some method of distinguishing them from the normal populations. And this is one of the challenges that we have is, all right, if you want to protect HIV, sickle cell, drug and alcohol abuse, how do you do that without a manual review of millions of records? We do have the notion that this could be done in an automated way. And so records could be automatically designated as restricted by some kind of review of the health record. So in addition to this restricted population that's controlled by policies that are organizational, jurisdictional, legal in nature, you have another population, a subset of the normal population, that really don't want to share their information, and so they can submit a restriction request. A restriction request saying either a partial or full restriction of sharing their information. Again, these two ends, the people that submit authorizations and the people that submit restriction requests, we believe, are really small categories of the overall population. The majority of people do desire that their information be shared because it's to their benefit to share that information with their providers and to make sure their providers have full information about them for treatment purposes. So in my hypothetical approach, you would have an opt-in for patients that have restricted information in any category, and they would be automatically or manually opted in by default and would have to consent to full or partial opt-in by signing an operation. For the opt-out category, without restricted information, they would be opted in by default. Their information would be shared with implied consent, but they could self-declare some of their records as restricted. They could then opt out by means of a patient's self-designated sensitivity or by signing a restriction request. There's a big assumption here that we have the technology that exists in the electronic health record space, and appropriate policies are in place to determine which patient records are considered restricted and which are not, and appropriate training for all staff on the processes. But the benefits of a hybrid approach is that it protects patients and organizations with sensitive information. It preserves patient choice. Patients can self-designate as restricted. it significantly reduces the administrative burden on patients and organization by eliminating authorization management for potentially millions of patients. So the question is, well, how do you actually do this? Well, part of my job is, as I'm the co-chair of Security and Health Level 7, and we develop healthcare standards, particularly in the security realm. It's the security working group. And I've been working with ONC, worked with the Data Segmentation for Privacy initiative of ONC's, which Helen had referred to. So in the hybrid approach, we require that EHR systems identify the indicators of restricted health information for automated segmentation and security labeling. Well, working with ONC, HL7 passed a normative standard for data segmentation for privacy, an implementation guide that actually specifies for developers how to do this. To supplement that, HL7 also passed a standard we call the Healthcare Privacy and Security Classification System. So in order to classify data for security purposes, we need to have some standardized mechanism to classify it for confidentiality, for sensitivity, for integrity, for compartment, and for handling instructions, telling people the processes or what they need to do once they receive information. Do not redisclose without patient authorization, et cetera. So in January of this year, following up on the S&I activities, HL7 passed 3 standards, the IG, the Healthcare Classification System, and a 3rd standard was also passed as normative, which describes the services that would and requirements that would need to be provided by a security labeling service, where it fits in the security organization services, and also what we call privacy protective services. And the privacy protective services would act on the security labeling in order to meet some policy, which might be to mask it, to anonymize the data or portions of the data, this kind of thing. So the system operates on the notion that data is structured. We look at the information that's in SNOMED or RxNorm or LOINC or these kinds of things, and there are rules then for the security system looking at the labels, then to label the data for security and privacy based upon the patient's consent directive, based upon the organizational policies and jurisdictional policies. So it provides a way then to segment the data for security purposes. You can think about a jar of jelly beans. If all the jelly beans were the same color, you would be able to tell one jelly bean from another. You wouldn't be able to tell the cinnamon from the spicy hot from whatever. But if you color the jelly beans, now you can know that. You know the red ones are spicy hot. And that's what we do with data segmentation for privacy. We enable flagging of the record for VIPs, for sensitive conditions, for whatever the policy requires, so that it can then be automatically enforced by an access control system to ensure that the patients and the organizational policies are met before anything leaves the door. So at the end, this provides an automatic method to do to automatically control and manage records designated as restricted by regulation, restricted by the organization, designated as restricted by a provider, by the privacy office, by the release of information staff, or at the patient's request. And for all others, we would have an opt-out policy that allows them to share their information without having to fill in any kind of paperwork or sign an authorization. As I said, they're always free to sign a restriction, and the community that is specified by policy and law that need to be restricted are restricted. The system is intended to be principally automated. Obviously, there's always going to be the need for clinician oversight and to make sure that the records are properly annotated. We're going to be looking at things like, the progress notes, the medical histories, the encounter diagnoses, things like this for the sensitive indicators. So in this way, we can have a system that works. There's always going to be people, though, that say, I don't believe this, I'm not going to do it unless, I see it in practice for millions of people. We're looking for early adopters here. There have been demonstrations. There have been 3 demonstrations already under the SNI initiative. At HIMSS, we've done demonstrations of eHealth Exchange. We've done demonstrations of direct, and we've done demonstrations of high-tech self-pay with these kinds of systems. So it's an emerging technology. The standards are there, however, and we already, probably most of us, already doing data segmentation to some extent anyway. So this really puts it on the high road and puts it in place for going forward. So that's all I have to say. Thank you.
Thanks, Mike. We're gonna leave you now. I mean, we'll come back to you, but I'm gonna put up a PowerPoint for Randy, so we won't be able to see you anymore, so you can take a break.
Thanks.
I don't know if he can see it. I should know that. Yeah. Hopefully he can hear, though. Okay. Randy, there you go.
Hi, good afternoon. Thank you, Deborah, again for holding this magnificent summit and for involving us here to share our stories. I have to say, I really enjoy participating in these types of summits. Not only because I think as a native Delawarean we have a really neat story to tell with regards to our HIE, but it's always fascinating to hear other stories. I mean, we have 50 states for a reason, right? It's great to hear how other states are trying to approach the cause of the common good, and how different but still very well-meaning and well-placed the efforts are in other places across the country. So I appreciate that. Real quickly, I just wanted to let you know a little background about our organization. We are the first and most mature statewide health information exchange in the country. And this is kind of like the product of an advantage of being a small state. Delaware is the second smallest state in the nation. There's kind of like a joke among us locals that there's about 2 degrees of separation between any of us in the state. Chances are, if you're speaking with somebody and you just met him, you probably have a few friends in common. And with that, problems get solved, and people are easy to get together in a room and collaborate and cut through red tape and cut through politics a little bit more. Well, I'll just say we seem to be able to do that, at least on the health information side, pretty effectively. Legislation was signed back in 1997 to create a statewide health information network. The purpose was really for this to serve as a electronic post office of medical results. And that was generated actually through many years of study within the state, asking the medical professionals involved in the care of the patients, asking the hospitals, the labs, radiology firms, if we did one thing really well, what would that be? What would the center of excellence be for our organization? And they said, look, if you do one thing really well, deliver results. Make it easy for me to see the information about the patients that I have requested that I need in order to perform care and be an effective physician. Because right now we're drowning under paper. And it's one thing to have too little information. It's a whole other deal to have too much information. Which is worse, that is debatable. I guess they're both bad for different reasons. So that's what the folks that preceded me at the organization went ahead and put together, and working with our vendor Medicity, created the Health Information Exchange that it launched in May of 2007. We currently have over 7,000 users, 726 practices and organizations, which may not sound like a lot, but if you look at like our rankings in terms of like ONC related organizations, we are among the top 5, top 10 in terms of volume, not just percentage. It's easy for me to say we got 100% of the acute care facilities participating in the state. I said that in front of the CEO of the Kansas organization. He goes, what do you got, like 7? Well, 6, yeah. But, it took a while to get them all to agree, but we're happy to get them there. And she goes, well, I've got like 100 or so hospitals that I got to get on board. But I said, with the measure of pride, yeah, but how many from Maryland do you have? And so, because we recently had enrolled a hospital in Maryland. So we're expanding our footprint because healthcare knows no borders. And it's great to be able to provide information to doctors, even when their patients seek care outside of our state's boundaries. We have 100% of our long-term care facilities enrolled, state nursing facilities. We make 14 million deliveries of medical results a year, and we have 1.7 million unique patients in all 50 states. Patients from all 50 states are represented on our network. And bottom line is we provide secure results delivery in a standard result format. It's really cool. I'm sure like those of you that work with HIEs, you can relate to this, because when you have like 20, 30 or so data centers, it's really nice to be able to provide a common format for the clinicians to be able to consume the information that's being provided. Yes, there's a different logo, but man, when you want to see the blood panel, you get used to seeing all that information in the same location regardless of who's providing that. So that's again, I think a very value-added component to the type of work that we're all involved in. Delaware is in that kind of in that in-between stage of having reached sustainability. We do not receive and do not depend upon any in-kind funding, such as like state money allocations or federal allocations. We provide a service to hospital labs, radiology firms, and they in kind also pay us for the services that we provide. We are looking to make that next level of leap in terms of the types of services that we're doing and becoming more innovative. And that's in the area of like providing PACS reporting and imaging studies, which a functionality that we recently launched with 3 data centers. And we are in the process also of working with an EMS organization, Emergency Medical Service, and doing an integration with that company to help with emergency medical responders so that they have information and can upload information to those doctors and the care team that will be looking to receive a patient and transport. So some very exciting things going on. I think Corinne mentioned earlier that I come from the financial services area, and one of the things that I felt like I brought to this discipline was a little bit more of a consumer mindset. And one of the first things I wanted to do was get an idea in terms of how consumers viewed HIEs, how they viewed our organization, how aware are they of our organization, and how would they feel if they weren't aware about us? What kinds of things would they think? The picture that you see here was a result of an exercise that we did with one of the focus groups. We had like 8 focus groups, 10 people in each focus group, as well as did a backup quantitative study. But these are some of the pictures that people had ripped out of a magazine to represent how they feel when they heard about DIN as a health information exchange. And these are Delawareans. Common themes are relief, stress-free, peace of mind, the fact that my information of my parents and my children would be there when they went to the emergency room was something that made them feel safe and confident, protected and secure, but also concerned. And one of the really telling aspects of this exercise, and it was so powerful, is that there were several participants in each focus group that just came down like the hammer of God. So it's like if it's on the web, anybody can see it, no matter how you want to like try and position it, because folks are coming in blank screens, so we weren't trying to bias them, but they are predisposed to the position as just like my information's not safe. How do I know what's going on there? How do I know who's looked at my information? And while that precipitated more often than not into a very interesting discourse, which was instructive, I have to tell you, between the other participants in the focus groups, it became clear to us is like when we start offering patient engagement tools, it needs to be on a foundation of transparency. Because if we can't offer transparency, it could totally disrupt the good that we're trying to do as an HIE. And if we can't provide a line of sight and provide that peace of mind to all consumers that the information is being used for the intended purpose of clinical care, we will be forever stuck in a maelstrom of trying to explain our way out of that sticky and cumbersome accusation. So it was a very instructive and very helpful exercise, I can tell you, in terms of getting that consumer feedback. So if you take nothing away from this session today, I would say is that the transparency is the foundation by which all HIEs need to operate as they start to offer patient engagement tools. So, real quickly, just to wrap things up, we have taken a number of initiatives to make people aware of our organization. We were recently featured as a cover story in the Morningstar Business Report, as well as, and maybe some of you that went to Paris this past December on American Airlines, you may have noticed on the international flights a 3-minute video that featured our organization and the great work that we're doing, and we continue to promote ourselves in the local environment. So Delaware's real quick, Delaware's an opt-out state, meaning everybody's assumed to opt in. The patients can opt out of being part of our community health record, meaning that their information would not be searchable by a provider that's not associated with their care. And we are looking to implement more granular opt-out options this fall with an upgrade from our vendor. We would have certainly done that sooner, but the technology is just becoming available, and we're doing it as soon as it is available this fall. So I look forward to entertaining your questions.
Great, Randy, thanks so much. I want to get Mike back. I hope I can get Mike back somehow. Though I think I might have clicked him away.
He's still there.
He's still there.
Click on that orange go to button.
Click on the flower.
Click on the flower.
On the bottom.
Yellow flower on the bottom.
Next to
Got
the
it.
flower. Hey.
Hi. You're back, Mike. You're up on the screen. So I'm going to ask if the audience has questions for the panelists. But, yeah. Hi. But I want to start with one. We heard from all of the panelists sort of varying degrees of experimentation, I think, with technology to offer more granular protection of patient privacy, both of different kinds of people, like VIPs and employees, but also of different types of information. And I guess, I remember LaTanya Sweeney once telling me that the outlook from the federal government many years ago was that they wanted to see how 1,000 flowers could bloom across the country in terms of developing privacy technology, and instead what they saw was 1,000 weeds fester. But I'm actually heartened by some of the things that I'm hearing about technological capabilities. But across the country in the laboratories of these state health exchanges, policymakers and architects are saying that data segmentation just can't be done. I mean, we still hear that, even though I come to these conferences every year and hear that it's being done, and from the VA more than anything else. How do we get this information that we're hearing today to the policymakers who are making these decisions, very expensive decisions at the state level? And I put that question to all the panelists. Are you ready to go on a speaking tour, Mike?
Well, I mean,
Sure. I'm
go ahead.
happy to take a shot at this. So the technology is pretty well known, and as I mentioned, the standards are in place. ONC has been pursuing this vigorously with their data segmentation for privacy initiative, and I think that's borne good fruit. They've tried to reach out by means of the HIMSS demonstrations to show that the technology is available and is viable. But in this area, I think early adopters are really critical. Those companies that see this as an opportunity for them, economically or otherwise, to step in and to provide solutions. As I mentioned a minute ago, there are lots of folks who simply will not adopt until there are operational systems in place involving millions of patients. But critical to this are the early adopters. Meaningful use criteria here would help, And again, I believe ONC is looking at this. I'm not speaking for ONC. I just say I believe that they are looking at this as a meaningful use option at some point. And the opt-in, opt-out that we've been discussing today is really a low bar for adopters using simple, restrictive tags to enforce the disclosure of protected health information. With this infrastructure in place, this very simple infrastructure for being able to handle the restricted information for, we've been talking about an opt-in, opt-out, very simple. You can extend that to more complex and detailed segmentation opportunities. So that's my view. I think this is what we need to do, is start seeing people actually kicking the tires on this and trying it in areas that are not necessarily totally critical to healthcare, but are significant to our patients.
I'll just chime in real quickly from the private sector. I mean, of the dozen or so organizations that I've worked with in New Jersey, only one has really foraged into data segmentation. And I think a lot of the limitations stem from, first of all, cost, and second of all, just the technology. So I'm not sure if I'm aware what the VA uses in terms of if it's a proprietary software. But what we run into in the private sector with the HIOs is simply, well, the technology doesn't do that, and in order to buy something additional, we don't have it in our budget. It's just too costly. So the more that it becomes mainstream and required, and the other issue is, quite frankly, even with the application that is involved in the Virtua Health, there's the issue that the sensitive information is not discrete data fields. They are freeform in documents sometimes that are PDFs, and once the information gets tagged, the whole document goes behind. So you might be losing valuable information just because a sensitive data field or a sensitive word appears in a freeform document. So, and that goes back to technology now, again, pushing the technology to really not just, churning out software and getting it out there into the marketplace, but really listening to what the limitations are and listening to people in the private sector and implementation issues and challenges and getting real meaningful solutions to those issues in technology.
Yeah, absolutely, Helen. And I would say that it's not a matter of not having the heart in the right place or not having good ideas in these areas. It's really a matter of a lot of times just not having the tools or the toolkit available in order to implement things and as quickly as we would like.
I'm sorry, I took the question, and I think we're out of time for other questions.
Yeah, I apologize, y'all. We have a 5-minute break and then another fabulous panel. But I know that all of these wonderful people would accept questions, and we'll make sure that they get your questions and answer them. I think this is the fascinating beginning. We need to have you all back next year because HIEs are going to blow more information around to more people, and the public doesn't really understand this yet, what the end users do with the information, where their information goes, and every state's adopting them. So we thank you for telling us so much about the solutions you have and the solutions you've seen, and we need you back again. And so everybody has 5 quick minutes. And then we have our next panel, David Staggs. You want to get everybody up?
Yeah, 55.
Thank you.
Hey, Adrian, how are you? Nice to see you again.